Hi, everyone.
Hi, good afternoon, everybody. So, Dr. Horn,
Dr. V.
today we're going to be talking about community-acquired pneumonia, and we've got some updated studies. I think this is, something that we get a lot of questions on, and it can change. Like the recommendations and things, after a while they change and they get updated, and we have some interesting things, labs to check, ways to treat the patient that are rather new that I think they're great things to talk about, especially with all the questions that we get about is this antibiotic okay? Is this enough days of duration of antibiotics for the patient? Do I need MRSA coverage? I think these are really great questions.
Yeah, so we're going to focus a little bit on the older guidelines that not so old in 2019. So plus the new studies that just came out.
All right, so we'll start with risk factors for community-acquired pneumonia. So we're going to talk about different types of pneumonia. And when it comes to community-acquired pneumonia, so these are patients that get sick in the community. And so they have a pneumonia and then they're admitted to the hospital with a pneumonia. Or they're treated as an outpatient with pneumonia. But they're getting pneumonia out in the community, which is going to be different than hospital-acquired pneumonia. But as far as risk factors go, we've got age, so older age, of course, cigarette smoking, viruses. So if they have any recent viruses, whether it's COVID or influenza, really any viruses will make people more susceptible to bacterial infections.
I think like this particular winter season, I saw not just COVID influenza, but also RSV, human metapneumovirus was a lot, especially in our COPD patients.
We have someone now with parainfluenza virus.
Yeah. So lots of viruses. Basically, they damage the lung cells, epithelium, and like how we get rid of our secretion. So it just puts at a high risk right after that to get pneumonia.
And we're also seeing coronaviruses, the original coronaviruses, not COVID, but and it's feels kind of, I guess, refreshing to see other viruses out there that are not COVID, but we're seeing a number of different viruses that we haven't seen in a while.
And definitely that's put you at risk for like bacterial superimposed infection. And of course, if you have alcohol use, it really hurts your tumor necrosis factor, the inflammation in our body, and that leads to increased gram-negative bacteria infections. So if a patient has like ETOH use, severe use, they're also at high risk for getting gram-negatives pneumonia. So have to think about Pseudomonas and other gram-negatives on top.
And then inability to protect the airway. So this is in people that have strokes and they're not conscious enough to protect their airway, seizures, so also intoxication. So when people drink a lot, they'll drink a lot, and then sometimes they'll get a right lower lobe pneumonia, which is something you can see when people will come in and they'll have a right lower lobe pneumonia, and I'll ask them, have you been drinking a lot of alcohol lately? And I've had a number of people say, oh, I was just on a cruise and we drank a lot, or I just recently I've been drinking more than usual. But right lower lobe pneumonia is something that I ask those kind of questions with, especially.
Just for my learning too, as I'm learning, do you think this is more also to like aspiration as well? Type?
Oh, yes. These are aspiration pneumonias. Yeah.
So right middle, right lower lobe, high risk for aspirating because the way our lung bronchus is. And of course, our patients with immune system that doesn't work really well, so they're really at high risk for pneumonia. Cystic fibrosis patient, COPD patient, bronchiectasis patient, and patients, of course, with cancer of different types. So it's really important to kind of know all the risk factors, and there's many more, but these are some of the high risk factors.
Yeah. So when the patient says, why did this happen to me? Right? These are the kind of answers I would give them. I usually would say to those questions, well, we think of the type of patients and the risk factors, and here are the risk factors that would apply to you. That's kind of how I talk about it.
And also just verbally, like we don't have a slide on this, but if you're a higher risk patient, make sure we're also vaccinating them appropriately. not just for like COVID or influenza, but making sure they have their pneumococcal vaccine. And now I remember we used to have pneumococcal 23 and 13, but now the new guidelines is you could just do pneumococcal 20. So also remembering for our patients when they're in the hospital that they're up to date on pneumococcal 20 or outpatient too.
Yeah, an update on vaccines would actually be a good topic.
Yes.
That can save them,
Yes.
maybe able to save them a hospitalization
Yeah.
in the first place and prevent it. So pneumonia classification. So here it has location. So the where it is in the lung or organism, whether it's viral, bacterial, typical or atypical, and then a fungal infection, how infection is acquired. So it's community acquired, hospital acquired, ventilator associated, or aspiration.
Yeah, the lobar pneumonia, you picture parts of the lobe of the lungs just fully infected with pneumonia. And then, of course, atypical pneumonia, when it comes to like, Legionella or something like that, it's patchy in the X-ray. So you see a different type of X-ray finding.
And then here again, here are the definitions. So there's community acquired, there's hospital acquired, and ventilator associated. And so I think these are some good definitions.
Yeah, and the only difference between community hospital and ventilator associated pneumonia is 48 hours after either admission to the hospital or 48 hours after being intubated with the ventilator.
And the reason we separate these out are because of the organisms, because you would give different antibiotics for different situations. And if there isn't a difference in the organisms or how you would treat them, then those definitions go away.
Yeah.
So diagnosis and treatment of adults with community-acquired pneumonia. This is the American Thoracic Society document, and it's also endorsed by the Infectious Disease Society of America. So they form it together.
And this was updated in 2019. It was long overdue. So we'll go through some guidelines and new studies now. So one of the first questions we always have to ask is if somebody's coming in with pneumonia, if they're outpatient, they're pretty stable, you're worried about pneumonia, you could just give them antibiotic and see how they're doing. But if it's a severe pneumonia, they're getting admitted, you're worried about MRSA, Pseudomonas, they had past history of MRSA, Pseudomonas, they've been in and out of the hospital. In those type of scenarios, it's really important to get a sputum culture. I don't know, you could tell me about it a little bit, Dr. Horn, but like I struggle when I have patients to make sure that we get sputum culture. And even if we order, I sometimes struggle to actually get the sputum culture. So it's so important because a lot of times if there's MRSA in the sputum, this is what's causing the pneumonia. So sputum culture is really valuable, especially in the severe hospitalized patients. Yeah,
I think I completely agree. If anyone that's hospitalized, you should be getting a gram staining culture.
Yeah.
And that the reason is exactly what you said, because if you get it, it can be very helpful. So in the outpatient setting, if they're not that sick and you're already treating with an antibiotic, the yield on sputum cultures isn't great, but in the hospital, you need to do everything you can to get identification of the organism. So in the community, in the clinic setting, it wouldn't be something that you would need to get routinely.
Or if they're mild community-acquired pneumonia on the floor and they rapidly get better and they leave, I think that's okay. But you have severe pneumonia, ventilated, past history of MRSA, Pseudomonas, or in and out of the hospital with a lot of comorbidities, I would strongly encourage us getting sputum cultures.
Should blood cultures be obtained? So again, they said not routinely because they don't want to lock everyone into having to get sputum cultures and blood cultures for every single community-acquired patient. But again, if they're in the hospital, then I would get blood cultures and sputum cultures if you can.
Yeah, so if you're severe, past history of again, MRSA, Pseudomonas, a lot of comorbidities, they've been admitted to the hospital in and out. So those, high-risk patients, we should be getting blood cultures. It kind of falls into the sepsis protocol too, right? It's important to get blood cultures if able prior to antibiotic, but otherwise give antibiotic as well.
Yep. And then should Legionella and pneumococcal urinary antigen be tested on everybody? And it says not routinely. Now, if people are going to the ICU, I think checking Legionella and pneumococcal urine antigen would be a very good idea. One of the things that people will say is they'll say, we don't see a lot of Legionella, so should we be checking Legionella on people if we don't see it? And that's a two-parter, I think. I think that's number one, if they're not seeing it, it could be because they're not checking it. So if you don't check it, you'll say you'll never see it.
Yes.
But the other part is, especially in patients that are worsening on beta-lactam antibiotics. And so if they're worsening on beta-lactam antibiotics, they might have Legionella, where the treatment is going to be not a beta-lactam. So they're not getting proper treatment. And especially they'll say in patients that drink a lot of alcohol, or they have certain risk factors, like they have a water connection or something like that. But
Yeah.
so if they're very sick, I think checking would be a good idea.
Yeah, so Legionella urine antigen and Legionella strep pneumococcal antigen are helpful. Again, not routinely, but severe or and also outbreak setting. You know, surprisingly, I get a lot of Legionella, like, you know,
We have one right. We have one right now.
yeah. So like when it's like all of a sudden we're like, whoa, you know, you
Yeah.
didn't expect it. And the treatment for Legionella, just so that we know, it's not ceftriaxone, it's not Augmentin, it's either doxycycline, levofloxacin, or azithromycin.
Mhm.
Sometimes some of the Legionella pneumonias that I get, they're so severe, I have to double cover with like doxy and levo, or doxy and azithro, levo and, you know, just combination, because those are atypical. And you actually have to do a longer duration of treatment if you have Legionella, like 2 weeks of treatment or so as well. So just be thinking about it. If you have severe pneumonia and if the chest x-ray said atypical presentation and things like that, that we should be getting urine antigen for Legionella and strep pneumonia.
And the Legionella urine antigen only does some serotypes in the urine. So we've had patients where that's negative, but the PCR, if they do a bronchoscopy, you can order Legionella PCR, and that can sometimes be positive. But yeah, so if a patient is very sick and you're not sure why, you know, that you should also be getting those. So now when it comes to influenza, should respiratory sample be tested for influenza at the time of diagnosis? So if influenza is in the community, then yes, you should be testing for influenza as well. Now, if there's a huge outbreak and a lot of people have influenza, you could probably assume that they have influenza, and you wouldn't need to test it.
This past winter, I felt like we used a lot of fourplex, which had influenza A and B, COVID, and RSV, which was helpful. And a lot of times in the inpatient setting, we used a lot of respiratory pathogen screen, which has like many targets for all the viruses. So that was helpful too. That's how we ended up picking up a lot of the human metapneumoviruses and all the other viruses too.
And then when it comes to procalcitonin, so should procalcitonin be used in addition to your clinical judgment, or just your clinical judgment without a procal? And so I personally like procals. This is empiric antibiotic therapy, should be initiated in adults with clinically suspected and radiographically confirmed immune-acquired pneumonia, regardless of the procal. Like I said, I like procals. But if you're deciding to start antibiotics, you wouldn't use the procal with your decision to start antibiotics. Usually procal is used to stop and not to start antibiotics, if that makes sense.
Yeah, and also I always think like X-ray says you have pneumonia, procal is 0, very normal. That doesn't mean the patient doesn't have pneumonia. X-ray shows that they have pneumonia. So it's a prognostic marker for me than a diagnostic marker. So like somebody has pneumonia and their procal is 4, and the second day their procal is down to 2. I'm like, it's 50% less than how it started. They're doing well. So it's a nice way for me to trend. It helps, but just be careful that if they have pneumonia and radiologically symptomatically, procal is 0 doesn't mean they don't have an infection.
Yeah, you should always use your clinical judgment. Sometimes, you know, I've heard stories of people getting into trouble because they'll say, well, I think this patient has a pneumonia, but the procal is low, or their white count is low. You know, even if they didn't have a leukocytosis, I would still say they have a pneumonia. So if your clinical judgment says one thing, but the lab says something else, you should always go with your clinical judgment.
Agreed. So this was a really nice study that was just published a couple of years ago, where they looked at procalcitonin with CURB-65. So how does that give us a better predictive value of like how the patient is going to do with community-acquired pneumonia? So they had over 2,000 patients in the study, and a median length of stay was about 10 days. And all-cause mortality in 90 days was found to be about 2.19 of all patients. Procalcitonin was identified as an independent predictor for prognosis of community-acquired pneumonia. CURB-65 in combination with PCT outperformed other predictive models at 90-day. So what they found is that when you use procalcitonin is a good marker for assessment of severity and 90-day mortality of community-acquired patients. The combination, when you use procalcitonin and CURB-65, was more accurate than prognostic model in predicting 90 days. So let's say that you have a patient with elevated procalcitonin at 5, community-acquired pneumonia, and it's coming down nicely. It really helps you treat the patient using combination values instead of just using CURB-65 or just using procalcitonin by itself.
Yeah, and I think this is a great idea, taking CURB-65, which is good, and then procals, which are good, and combining them. I think that's
because one of the things that people talk about is like the pneumonia severity index. The problem with that is, including in this guidelines in 29, they tell you to use it, but there's so many variables, and it's so hard to like getting all the variables to be able to like get the numbers, but versus like you have procal and you have CURB-65, which is easy to do, and you have a quick answer.
And then this is, should a clinical prediction rule for prognosis plus clinical judgment versus clinical judgment alone be used? So this is essentially their wording to say, would a clinical prediction rule for prognosis be helpful for inpatient versus outpatient treatment location? And this is what you're saying about pneumonia severity index. They like pneumonia severity index, but it's got so many variables that you have to order labs, you have to wait for those labs, you have to cancel all your clinic patients for the rest of the day, and then figure out this pneumonia severity index score. So it's just too much. I think sticking with CURB-65 would be,
That's why I like the study combining procal with CURB-65 to help you better gauge the patient. So CURB-65, so how do you calculate it? You give points for each of these. So confusion of new onset, blood urea nitrogen greater than 7 or 19 milligram per deciliter, respiratory rate greater than 30 per minute, blood pressure less than 90 systolic or diastolic less than 60 or less, and age greater than 65 or greater. So if you have 0 to 1, outpatient, you could take care of them. Greater than 2, so let's say the respiratory rate is 30 and they're confused, they should get hospitalized. Or their age greater than 65 and their respiratory greater than 30, they should get hospitalized. So it's like if you have 2 of these points, hospitalization, but if you have 3 points, so they say confusion, tachypnea at 30, plus they're over the age of 65, now they're at 3 points. So these type of patients should be considered to go in the ICU. But it also helps, you can use this with the procalcitonin of 4 and go, okay, they go to the ICU and we take care of them there. So it's quick, easy way to do it. So we are kind of going against the guidelines a little bit, but if it's hard to calculate all that, this is a nicer way to do it with procal.
Yeah, so if you have it's essentially like if they're in your clinic or in the ER and you're deciding where should they go in the hospital or should they go in the hospital, they can look very different. Some people will come in and say, oh, I think they should go here or there. This is to get everybody on the same page and realize how sick a patient really is. And so the only one you need a lab for would be the BUN, but if they already get enough points through the others, then you wouldn't need that lab anyway. So here's CURB-65 applying at 0 or 1 low mortality, outpatient treatment. This is going to be a score of 2 intermediate mortality, which is 6.8% mortality, hospitalization, and then 3 or more high mortality, think ICU. And it makes a difference because if someone goes to a medicine floor and they should have gone to the ICU, then their likelihood of dying is higher than if they had gone straight to the ICU. And so if someone goes to a medicine floor and then within the first 24 to 48 hours transfer to ICU, then they'll say that they probably should have gone to the ICU in the first place. So that's why that curve 65 is important. Yeah.
So in adults with CAP, in outpatient setting, which antibiotics are recommended for empiric treatment for community-acquired pneumonia in adults? So this is for our patients in the ER, in urgent care, in our clinics. What should we use for antibiotic, right? So if you have a patient that's coming in and they have no risk factors, no MRSA, no Pseudomonas, what they're recommending is you could use amoxicillin. It covers like strep pneumo really well because that's one of the big bug in outpatient setting. And then or doxycycline. Doxycycline is not the best for strep pneumo, but it's okay. Or they say macrolide. I stay away from macrolides. Macrolides are azithromycin. Many communities, for example, in Nebraska, macrolides are over 45% resistant to strep pneumo. So we should not be using azithromycin to treat community-acquired pneumonia, because if you look on your right-hand side, the number one pathogen is strep pneumo. So if it's over 40% resistant, it's not safe to use macrolides. And many communities across US are very resistant to azithromycin for strep pneumo. So amoxicillin is great. And if patients have comorbidities, so let's say they have diabetes, COPD, comorbidities, then you could combination treatment. So you could use Augmentin, amoxicillin with clavulanic acid, or cephalosporin like Keflex, cefdinir, ceprodoxime, a third generation cephalosporin, and a macrolide or doxycycline. So now you're trying to cover for if you have comorbidities, atypicals as well. If you look on the right-hand side, atypicals like mycoplasma, chlamydia, those are all chlamydia pneumoniae, those are atypicals. So what you would do in a complicated patient with in the community, they have community-acquired pneumonia, you'll give them Augmentin with doxy, Augmentin with azithro. So you're combining. Of course, you could do monotherapy if you have comorbidities and community-acquired pneumonia with, for example, moxifloxacin or levofloxacin. Just beware, fluoroquinolones, there's so many side effects. There's FDA warning for like aortic root dissection. In elderly patients, you get, delirium, you have Achilles tendonitis, you have QTC prolongation, drug-drug interaction, C. diff, resistance. So fluoroquinolones have so many issues. I really stay away from using fluoroquinolones. I do see a trend in the outpatient setting. A lot of fluoroquinolones are used, but if you could avoid fluoroquinolones and use for complicated patients with community-acquired pneumonia, combination treatment is so much better, like a third generation cephalosporin or Augmentin with doxy or azithro.
Oh yeah, I completely agree with that. I think, and this most common etiologies. So these are patients that got community-acquired pneumonia. So they got their pneumonia in the community, and then if they're treated as an outpatient, the most common things, or if they're sick enough to be inpatient or sick enough to be in the ICU. And then if you look, Staph aureus is down here, so they can get Staph aureus as a cause of community-acquired pneumonia, but and it can make people very sick, but it's not one of the huge causes. So because a lot of people will think, well, what about Staph aureus? But strep pneumo, like you said, strep pneumo is number one here in inpatient, number one for ICU. And so strep pneumo can make people very sick very quickly.
And I think also one of the things that I always do is always look at past culture when we have patients. So if I have a patient coming in and getting admitted with community-acquired pneumonia, but when I look at the past culture and they just had MRSA last week or 2 weeks ago, then of course that goes on my top of my list. Okay, I got to cover for MRSA plus the strep pneumo. So for ID, it's always a good detective work, doing some digging, and always really important to make sure you look at old cultures. It's very helpful. So this was a really nice study. We get asked a lot, like, how long should we treat for community-acquired pneumonia? So this study was just published in March in 2023 in Clinical Microbiology and Infection. They looked at short course versus long course. And I know we talk about this a lot, but again, here's another big study with nice data. They looked at patients from 2017 to 2019 in 4 major systems in Denmark. And they gathered, when they looked at the data, they looked at 4 to 7 days for community-acquired pneumonia versus 8 to 14 days. And they looked at primary outcome was mortality within the first 30 days. So did the patient have a bad outcome? Did they die? Secondary was readmission and new antibiotics. And they looked for short versus long course, what happened to these patients.
Yeah, and so the short course, 4 to 7 days, or a prolonged course, 8 to 14 days of antibiotics. And the primary outcome was post-treatment mortality, and secondary outcome included readmissions. And basically what they saw was that similar outcomes were observed between the short course and the prolonged course. So that means whether they treated them for a short, just a few days versus the longer number of days, that the short course was fine. So that's why we say 5 days total would be
plenty,
would be enough. Yeah.
And this is a newer study. So this is what they said in this guidelines. But again, looking at this new study that was just published, there was no difference in mortality, 3.6 to 3.4, short versus long course. Readmission, 15.6 to 14. So really no statistic, no really significant difference. And then new prescription antibiotics, 11.9 versus 12.1. So really shows they looked at a really large population of patients to over 1,100 patients, 1,150 patients. So really short course of antibiotics is just as good. So part of antimicrobial stewardship, when you have pneumonia patient community-acquired, 5 to 7 days is plenty.
Yeah, so really, I don't think people usually have problems with duration of antibiotics. It's usually time to the effective antibiotics. And so once they're on effective antibiotics, it's usually not the duration. So, but I like these studies where they show that shorter is better.
Yeah, and this was just published recently this month.
And then in the inpatient setting, which antibiotic regimens are recommended? So we talked about outpatient antibiotics. So what are the antibiotic regimens recommended for empiric treatment of community-acquired pneumonia in adults without risk factors for MRSA or Pseudomonas? And so they break it up and they say non-severe inpatient or severe inpatient pneumonia. And so for non-severe, they have beta-lactam plus a macrolide or a respiratory fluoroquinolone. And then for severe, it's beta-lactam plus a macrolide or a beta-lactam plus fluoroquinolone. Is the standard regimen. Now, prior respiratory isolation for MRSA, essentially for severe, you would add MRSA coverage and do cultures. And if it's negative, then you can stop it. And then for non-severe, you would take cultures and then add MRSA coverage if it's needed. So the question is whether you can withhold the MRSA coverage if the patient's doing okay or not. Is that kind of how you think of it too? Or,
I do. We're putting together some order sets, and I know our antimicrobial stewardship pharmacist Sumaya is working currently on the MRSA, when to test and when not to test. So she'll be she's already working on the order set. But I really, really like MRSA nasal culture or PCR, depending on what you all have in your hospital setting, because it's really helpful in quickly de-escalating. And also, of course, if there's severe infections, if they have history of Pseudomonas, make sure we check and culture for that as well and de-escalate as when it's not needed.
Yeah, so I mean, if they have prior respiratory isolation for MRSA, if you're concerned about it and they're sick, I would add MRSA coverage and then de-escalate it if their cultures are negative or if they're improving.
Okay.
And then this is again the most common etiologies. So whatever you give, you want to make sure that you're covering strep pneumo really well. And then just keep in mind, it's kind of better to think of what are the bugs I'm trying to treat, and then which antibiotics would treat those bugs more so than the ICU. They always need this, or the in the medicine floor they always need that. It's better to think of what bugs am I trying to cover with the antibiotics that I'm choosing.
And kind of wanted to illustrate this study. This was a big study. It was done in 2014, but we have had many studies after that looking at nasal swabs. And again, want to kind of go back to why that's really helpful. So when you do a nasal swab on a patient that's getting admitted and you have them on, for example, Vancor, right? Because you're worried about severe pneumonia and you're trying to cover for MRSA. But if you do a nasal swab culture or nasal PCR, this is pretty amazing. MRSA PCR assay demonstrate 88% sensitivity and 90% specificity with a positive predictive value of 30, but negative predictive value of 99.2. In case of a culture negative pneumonia where the initial empiric antibiotic included MRSA active agent and negative MRSA nasal swab, PCR swab can be reasonably used to guide antibiotic de-escalation. So you have a patient with MRSA, either you have a culture or PCR. If it's negative, that tells you that you don't have to cover for MRSA. And we do this a lot to get rid of vancomycin MRSA coverage.
Yeah, and some hospitals will have it linked to their vancomycin order for pneumonia, which is a great idea. So if vancomycin is ordered for pneumonia, if it's possible to link an order to check an MRSA of the nares, and if that's negative, have someone review that for de-escalation and stopping the vancomycin is a good way to decrease vancomycin use.
And I do know a lot of places they don't have MRSA PCR machine. So you could also use MRSA culture as well. Usually culture takes about 24 to 36 hours to come back, but you could still have that back and stop and Vanco like in a day and a half versus 3 to 4 days.
Yeah, that's a really good point. Doing a culture of it would be a really good way to do it too.
In a setting, so they are talking about patients should be suspect aspiration pneumonia, receive additional anaerobic coverage beyond standard empiric treatment for CAP. No, don't routinely add anaerobic coverage or suspected aspiration pneumonia unless lung abscess or empyema is suspected. So it's really important if somebody aspirates, is it bad? Are you worried about lung abscess? Is they worried about like fluid between your lung and your pleural space? Then of course, anaerobes coverage should be added. So in cases of aspiration, so that's going to be important. Some have estimated that 5 to 15% pneumonia hospitalizations are associated with aspiration. So a lot of our elderly patients, they are high risk for aspirating. So also some of the good things to do when our patients are in the hospital is to put their head of the bed up at least 45 degrees, make sure they're sitting up when they're eating, because a lot of patients are at high risk for aspiration pneumonia.
And then in the inpatient setting, should adults with CAP and risk factors for MRSA or Pseudomonas be treated with extended spectrum antibiotic therapy instead of standard CAP regimens? And this was looking at abandoning the use of the term healthcare associated pneumonia, HCAP, to guide selection of extended antibiotic coverage in adults with CAP. And this is what I was saying, if the term doesn't have different organisms, or if it doesn't have a different way you treat it, then they get rid of it. So they realized that HCAP had the same organisms and it didn't determine how to treat them, so they got rid of it.
In the inpatient setting, should adults with CAP be treated with corticosteroids? So this is interesting.
This is a good one.
Yeah. So it says not routinely. Endorse the Surviving Sepsis Campaign recommendation on the use of corticosteroids in patients with CAP and refractory septic shock. So at that time, they said if you're septic shock, part of the sepsis campaign, you could use it. But we just had a major study published. So this study just got published in March of 2023, hydrocortisone in severe community-acquired pneumonia. And I was surprised to read this because it's back and forth. Give steroids, don't give steroids.
It goes back and forth all the time.
Yeah. So now what the study found, what they did was adults admitted in the ICU for severe community-acquired pneumonia, intravenous hydrocortisone was given 200 milligrams daily for 4 or 8 days as determined by clinical improvement, followed by tapering for 8 to 14 days, or they received placebo, so no steroids. all patients received standard of therapy. So everybody got antibiotic, respiratory support, respiratory, all the other stuff was completely same. But one group got in steroids and one didn't. What they ended up finding is among the patients severe community-acquired pneumonia being treated in the ICU, those who received hydrocortisone had a lower risk of death by 28 days than those who received placebo. This is significant finding.
Yeah.
So hydrocortisone, so if you look at this graph, percent of patient discharged from ICU was much higher for those who received steroids versus those who didn't. This is a huge paradigm shift again, because it just got published. So if you all have a severe community-acquired pneumonia in the ICU, it appears they will benefit from steroids, and they will have better outcome in the first 28 days.
So in adults with CAP, if they test positive for influenza, should the treatment regimen include antiviral therapy? So the answer is yes, and it's independent of illness, duration of illness before the diagnosis. So, even though it's been, it may have been a week, sometimes people, well, especially in the clinic setting, they would say, should we give oseltamivir for someone if they tested positive? How long ago did they test positive? And basically, if they're in the hospital, they should get treated.
Yeah.
Independent of the
Even if
duration.
it's like 3 days or 4 days, get treated with Tamiflu. It shortens the viral replication. And if you're immunocompromised, influenza replicates in your body 2 to 3 weeks. So even if it's been more than 72 hours, please give.
So if they're sick enough to be in the hospital, they should get treated. So sometimes people will say, well, it's been a while, I don't want to treat them, but that it's different if they're really sick.
In adults with CAP who test positive, and should they the treatment regimen include antimicrobial therapy? Yes. So if you have influenza plus pneumonia, you should give them an antibiotic, because influenza can put you at high risk for superimposed bacterial infection. But just remember, the biggest bacteria we worry about when you have influenza and pneumonia is MRSA. So you would treat them like CAP, but instead of doing ceftriaxone and azithromycin, do ceftriaxone and doxycycline, or ceftriaxone and vancomycin. But usually, if they're stable, doxy, that you're doing MRSA plus strep pneumo coverage. So the big bad bug, if you get an influenza, staph and strep pneumo. And
then exactly what you're saying. So when you have a viral infection and you're worried about a bacterial secondary pneumonia, strep and staph. So here it is. It's major bacterial. So it's Staph aureus, whether it's MSSA or MRSA, but you want to make sure that you're covering for MRSA. So MSSA or MRSA, strep pneumo, and then it has H flu here also. But really, it's I mainly think of the strep and staph. So when you look at their chest X-ray or you look at their CT scan, sometimes it's hard to tell, is this only a viral infection, or is there overlying bacterial infection? And if the patient is coming in with influenza or they're really sick,
how I always think too, that you have said in the past, they get better for a second and then they get worse all of a sudden. So like, you give them Tamiflu, for example, they get better, and then all of a sudden they're fevering. Now you're like, oh boy, they have a superimposed bacterial infection on top.
An acute decline. So so they'll say, well, the patient will come in and say, I was getting better, and then all of a sudden I got worse. And then you can think, oh, they probably have a overlying bacterial infection. And with influenza, when they look at the influenza outbreaks in the past that have had a high mortality, it's really because of the overlying bacterial infections that come in at the end. And I think that's everything.
Just as a summary, I would just take away would be like, if you have community-acquired pneumonia, if you're getting admitted to the hospital severe enough, sputum culture, blood culture, making sure we treat our patients appropriately for strep pneumo as the #1 bug, making sure we look at past cultures, high risk for MRSA Pseudomonas, making sure we cover if that is, and then de-escalating. But the 2 new things I want you all to take away is this: hydrocortisone for severe
Mhm.
community-acquired pneumonia if they're in the ICU. So really, that's new data that just came out.
That's going to be new for everybody.
Everybody,
Yeah.
yeah. So it's going to be new, and how do you get that incorporated part of your order sets? And other one is what is really helpful also is to get nasal MRSA culture or a PCR, because if you for some reason started a patient on MRSA treatment, and they were high risk, you could quickly de-escalate vanco and get rid of vanco. So I think those are some of the big takeaways. Do you all have any questions for us today? Anything we could help answer?
Yeah, if you have any questions, you can either type it into the chat or go ahead and unmute yourself and ask any questions that you have. I think this is one of the most common things that we see. So this is one of the most common things that we get questions on.
Yeah.
Yeah, if there are any questions, and this is also can be quite.
Oh yeah, there's a question.
Oh.
Is there a way to get a copy of? Yes, of course, we'll send this out.
Yes, we'll send a copy of the slides out.
Any other questions?
Hi, this is Val from Fillmore County Hospital. Can you hear me?
Yeah, of course.
Yeah.
Go ahead.
We just have a question. So on the hydrocortisone, where you're talking in an ICU, where most of us don't have an ICU,
Yes.
so it would not be beneficial to give our patients the hydrocortisone?
Yeah, no, I mean, what they're talking about is like really severe cases, Val. So like, you know, rapidly deteriorating, they're going to need like BiPAP or intubation, or like, you know, they're so like really bad cases of pneumonia. I'm not sure.
That's what we were wondering.
Yes.
And then the other question, so would it be beneficial then on a patient that we're transferring out to give them a dose of that before, or just let the receiving hospital deal with that?
I think if they're early on getting transferred, you know, you could tell the receiving hospital, you know, this is such a new data that just came out. I don't know how many people know it, right?
Yeah, right.
So we are all just starting to socialize and talking about this.
Yeah.
So
I would say if they qualify for it,
give it,
give
but
it,
then
yeah.
also tell them this is why we are doing it. Might be
Yes.
another good approach to saying, hey, they're so severe pneumonia, they're rapidly declining. We gave them a dose of hydrocortisone. You know, there's new data coming out. Make sure. I think all of us have to now start educating people because this is so new that just came out.
So we'll do this.
Thank you.
Yeah, of course.
Yeah, we'll do this question first. If you start MRSA coverage, can you still check a nasal swab?
Yeah, you can. It's helpful if you do it sooner than later.
Mhm.
But yes, you can. We do that a lot, the nasal swab. The next question, go ahead.
Oh, sorry. Yeah, I didn't want to skip this one. What is your opinion on vancomycin versus linezolid for MRSA coverage?
Yeah, so either one has good MRSA coverage, but I stay away from linezolid a lot. If you have bone marrow suppression, low platelets, you're on a SSRI because you have serotonin syndrome. Linezolid has a lot of interaction. So, but if they don't, maybe you could use a short course. So it's kind of tricky because linezolid has a lot of interactions and side effects.
And so if the MRSA, so anytime you have Staph aureus and you're using vancomycin, you do want to look at the MIC and make sure, you know, that's less than 2. So it should be about 1 if you're going to use vancomycin. In studies, you know, they would look at it and they would say linezolid. There are some benefits with linezolid, but it depends. I would say it depends because
on the
if you
patient.
have, exactly. It depends on the patient because with a patient with MRSA, the majority of patients can get treated with vancomycin and do very well. And so I try to reserve linezolid as much as I can. Now, if you have a patient that's extremely sick and they're really not doing well, I think linezolid would be a good option. But I try not to give linezolid to everybody with MRSA.
Like I think it's like weighing patient, like this patient has AKI, I don't want to use vanco because of it's going to get worse, and linezolid is okay. But then if you're going to use linezolid, make sure you check all the interactions and side effects.
That's how I see it. I try to use vancomycin first, but I have a low threshold to go to linezolid, especially if they're sick or if they have, you know, any kind of contraindication to vancomycin. That's how that's how I see it too.
A nursing home residents no longer considered healthcare associated.
Yes, they got rid of healthcare associated pneumonia. So that healthcare associated term they got rid of, and that would say if you've been in a nursing home or if you've been in a facility, so many days in the past, and they actually said, well, that doesn't change the organisms, and so they got rid of that term healthcare associated pneumonia. Yeah, that's a good question.
And I just think like it's really important when you have nursing home patients and just looking back old cultures, because that's going to really tell if they had Pseudomonas, MRSA.
Yeah.
Is there a rapid test to check for Pseudomonas? Unfortunately not. For Pseudomonas, sputum culture is the best to get. So, and sometimes when your patient cannot give you sputum, because that happens a lot, working with our respiratory therapist to do an induced sputum is helpful as well. So I think those are the only two ways to do for Pseudomonas, unfortunately.
Yeah, there's no rapid antigen check or anything like
Yeah.
that. Yeah, culture would be great. These are good questions.
Yeah. Any other questions you all have? Well, thank you so much for joining us today, and we'll see you guys again next month with a different topic. Thank you so much.
All right, thank you everybody.